Good evening, everyone. We welcome you all for the today's AOCN Allied Specialty Lecture Series on Cerebellar Anatomy and Localization. In this month, we have discussed a clinical approach to an ataxic child and OMA syndrome in basic and advanced lecture series. It's very important for the clinicians to understand and revise the cerebellar anatomy in order to localize correctly the anatomical site of lesion in children with cerebellar symptoms and signs. On behalf of AOCN, I would like to welcome our speaker for today's session, Professor Shyam Krishnan Nair sir, and moderator for today's session, Professor Lima Paulin ma'am. Sneha, can you go on to the CV slide, please? I'm very proud and privileged to introduce my teacher, Professor Lima Paulin ma'am. She is Professor of Pediatric Neurology in Institute of Child Health and Hospital for Children, Madras Medical College, Chennai. Ma'am has authored several papers in index journals, and her areas of interest includes childhood stroke, neuroimmunology, and neurometabolic disorders. We always call ma'am as the encyclopedia of neurology during our MD days. So now I request ma'am to introduce our speaker for the session.
Good evening, everyone. At the outset, I thank AOCN for inviting me to be a moderator for this session. And thank you, Sankita, for the nice words. And when we say cerebellum, or when we think about cerebellum, we know pretty well that cerebellum is the major organ which coordinator of movements, and it coordinates the motor movements. And to execute any motor movement, it includes an interplay of so many muscle groups, agonists, antagonists, synergists, and muscles for fixation of a joint. So we can say that the cerebellum is a conductor of an orchestra, or it is the master of an orchestra. Without cerebellum, the movements will be disorganized, will be clumsy, and to bring harmony, and without cerebellum, it will be disharmonious, and it will be just a cacophony. So so we are going to hear about the anatomy as well as all those connections, cerebellar connections, and localization, how to localize a lesion when we come across a child with ataxia, from none other than from our distinguished speaker of the day, who is none other than Professor Dr. Shyam Nair. He is the Professor of Neurology and in charge Comprehensive Care Center for Movement Disorders, Sri Chitra. And he is also the Dean Faculty of Modern Medicine, Kannur University. And he has authored around 50 publications in international and national index journals. And his areas of interest are Parkinson's disease and other movement disorders, and especially deep brain stimulation and Botox treatment for movement disorder. And we are pleased to hear from you, sir, for the next 30 to 40 minutes about cerebellum and everything about cerebellum. Over to you, sir.
Thank you, madam, for the nice words of introduction. At the outset, I would like to thank all the office bearers and of AOCN and the organizers of this webinar series for giving me the opportunity to present this discussion today in this August forum. Can I share the slides?
Yes, sir.
Yeah. Are my slides visible?
Yes, sir.
Yeah, we will discuss this topic of cerebellar anatomy and localization under the following headings. One, we will initially have a general look into a general layout of the voluntary motor control. Then a role of basal ganglia and cerebellum in motor control, because you cannot discuss voluntary movements without mention about basal ganglia. Then we will look into the gross anatomy of cerebellum and the topographical representations, connections of cerebellum, cerebellar cytoarchitecture and microanatomy, motor manifestations of cerebellar dysfunction and localization, non-motor functions of cerebellum, and then we will go into a few representative videos. This is basically on anatomy and localization, so we will not be discussing individual cerebellar disorders. genetics of cerebellar disorders, or management aspects. So this, my slides are visible to all now.
Yeah.
Yeah. So this picture shows a general, it shows the final common pathway for voluntary movements. As we all know, the final common apparatus to execute any voluntary movement is the anterior horn cell, the motor nerve, neuromuscular junction, and the muscle together, what we call the motor unit. The central control of movement is channeled onto the anterior horn cells through the corticospinal system, which is also called upper motor neuron, and other descending tracts. There are other tracts which descend onto the anterior horn cell, like the tectospinal, vestibulospinal, and reticulospinal tracts. These also exert influence on the anterior horn cells. The terminology upper motor neuron is sometimes loosely used to indicate both the corticospinal as well as the other descending tracts. Lesions along the corticospinal system and the final common pathway manifest as paralysis or weakness. But the motor output from the cortical areas, for the motor output from the cortical areas to be shaped and for any voluntary movement to happen, so 2-3 other prerequisites are there. One is that the most appropriate motor program or muscle group which need to be for the particular movement need to be selected, and its activation needs to be initiated, and other competing motor programs need to be inhibited. We know that in the cerebral cortex, it is not the muscles which are represented, but the movements are represented. So there are neural programs for different movements, and for any movement, the particular neural program which is involved in that movement need to be activated, and other competing motor programs need to be inhibited. That is one requirement for any movement. And we know that there are multiple muscles and muscle groups participating in each and every joint. Multiple joints are each and every movement. So there needs to be an ongoing real-time gauging, monitoring, and correction of the force generated by contraction of the participating muscles and the rate and range of movements, so that the movements at various joints occur accurately and occur very smoothly for reaching the target. So this is what is called coordination of movement. Now, basal ganglia is the selector of motor programs. So we know that basal ganglia, it is not an independent entity. It is part of a circuit called a cortico-basal ganglionic circuit, which is composed, which is from the cortex to the corpus titum, that is caudate nucleus and putamen, to the pallidum. Then it goes to the thalamus and the cortex. So we also know that there's a direct as well as indirect basal ganglia circuit. The direct basal ganglia circuit facilitates thalamic excitation of the cortex, and the indirect circuit inhibits the thalamic excitation of the cortex. I am not going into the details because this talk is not on basal ganglia. But what is important is that the basal ganglia does a selection job. We know that basal ganglia is not only motor, but there's a limbic basal ganglia circuit, there's an associative basal ganglia circuit, and sensory motor basal ganglia circuit. All of them form the same scheme of cortico-striato-pallido-thalamo-cortical loop. The cortical and the basal ganglia areas in each circuit is different. For example, in the limbic basal ganglia circuit, the cortical area is the anterior cingulate cortex. For the associative basal ganglia circuit, it is the dorsolateral prefrontal cortex and the lateral orbitofrontal cortex. And for the sensory motor circuit, it is the motor and premotor areas of the cortex. So the basal ganglia is the one which selects the movement. For any particular movement, there should be a goal. There should be a goal, or there's a motivation. Then there should be an action plan, and finally the movement. So in this one, for the movement, the basal ganglia, the motor basal ganglia circuit selects the motor programs which need to be activated. So the disorders of basal ganglia motor circuits result in abnormal selection of movement programs. So the basal ganglia selects and activates the desired movement, that is a direct pathway, or it inhibits competing unwanted movement programs, so indirect pathway. So failure to select and activate appropriate movement programs lead to paucity of movements, that is reduced speed and reduced amplitude, what we classically call Parkinsonism. While selection and activation of movement programs inappropriate for the situation, that is failure to inhibit the unwanted movement programs, lead to hyperkinetic movement disorders like dystonia, chorea, etc. And in many basal ganglia disorders, they coexist, that is hyperkinetic as well as hypokinetic movement disorders, or Parkinson's and hyperkinetic movement disorders coexist. For example, dystonia and Parkinsonism could coexist in several conditions. We know Parkin mutations and dopa responsive dystonia. These are conditions where there's a coexistence of hyperkinetic movement disorders along with Parkinson's. Cerebellum is the coordinator of movements, and cerebellar dysfunction results in loss of order or ataxia. So coordination involves multiple faculties. One is a real-time monitoring of where each body part is in space. For a movement to be executed properly, there should be the brain should know where each body part is in space on a millisecond to millisecond basis. So there should be a real-time program for monitoring the position of each body part in space, and a computation skill of the force to be generated by each of the muscles involved, and the duration and timing of contraction of each muscle to move the body part to the new position should be there. There should be a computation system. Calculation of the consequences of distal movement on proximal joints to facilitate stabilization. For example, in a distal movement, the wrist movement will also have some inertial impact on the proximal muscles. This is called rotation torque. When the wrist or the elbow moves, there is a rotation torque acting on the shoulder, and this should be stabilized. Otherwise, the movement will become erratic. The orchestration of the movement at each participating joint and stabilization of the proximal joint so that movements happen smoothly is a must. And there should also be a mechanism to receive information regarding any errors during the movement, and there should be a mechanism to correct the errors. For all this, the cerebellum needs 3-4 skills or 3-4 informations. One is an information on what the brain wants the body to do. That is a copy of the motor command generated in the motor cortical and related areas. Only if the cerebellum gets a copy of the motor command or cerebellum gets an information regarding what the brain wants the body to do, it can do these corrective measures. Second is a real-time information on where each body part is in space. That is, the cerebellum should have an internal map, or there should be an internal schema of each and every part of the body on a real-time basis. That is, it will change based on, depending on the movement which is happening, the body part's position will change. So there should be a real-time updating of the internal schema. Then a high efficiency computing system to integrate the two and form suggestions pertaining to the forces to be generated by each muscle or muscle group, again on a real-time basis for the movement to happen. That is the information on the internal schema of the body, that is the position of the body in each and every position of each body part in each and every millisecond should be integrated with the movement commands which are generated from the cerebral cortex. And finally, after the integration of all these, when cerebellum generates suggestions, cerebellum should have an access to the areas of the motor cortex which generate motor commands. So this picture, this demonstrates cerebellum has all these skills which we discussed, or has access to all the information which we discussed. So from the cerebral cortex through the middle cerebellar peduncles, information on what the brain wants the body to do reaches the cerebellum. So motor commands which are generated in the cerebral cortex, a copy of it is passed on to the cerebellum through the middle cerebellar peduncle. And through the inferior cerebellar peduncle, through proprioceptive and vestibular information, the information on where each body part is in space reaches the cerebellum. That is through the spinocerebellar pathways, vestibular nuclei, and olivocerebellar pathways. Cerebellum itself is the computational center, and the output to the motor cortex is channeled through the superior cerebellar peduncles, through the thalamus to the cortex. Part of it goes to the red nucleus, and bypassing the thalamus and cortex, it goes directly into the spinal cord through the rubrospinal tract. So the inferior cerebellar peduncle is an important connection of the cerebellum, and it mainly carries the information regarding where the body part is in space. It contains the vestibulocerebellar tracts, which channels vestibular information regarding head position to the cerebellum. Then spinocerebellar, cuniocerebellar, and trigeminocerebellar tracts carry proprioceptive information from the various parts of the body. Inferior cerebellar peduncle is thus the major source of sensory input to the cerebellum. There is one exception. Most of the input tracts go through the inferior cerebellar peduncle. One exception is the ventral spinocerebellar tract, which passes through the superior cerebellar peduncle. And olivocerebellar tract is of special importance. It carries information useful for motor learning. The only output tract through the inferior cerebellar peduncle is the cerebellovestibular tract. We have seen that inferior cerebellar peduncle is basically for input information to the cerebellum. There is one output tract which is going through it, that is the cerebellovestibular tract. All the tracts going into the cerebellum through the inferior cerebellar peduncle project ipsilaterally. Only exception is the olivocerebellar fibers which cross. From the opposite inferior olive, the olivocerebellar fibers reach the cerebellar hemisphere. Next is the middle cerebellar peduncle. This carries information as to what the brain wants the body to do. That is, corticopontocerebellar fibers arise from motor regions, descend with the corticospinal tracts, and cross in the anterior pons to enter the contralateral cerebellum via the middle cerebellar peduncle. The majority of fibers in the bulge of the anterior pons are those crossing corticopontocerebellar fibers en route to the middle cerebellar peduncle. So, information from the opposite cerebral cortex reaches the cerebellar hemisphere through the corticopontocerebellar tract, which crosses in the pons. Superior cerebellar peduncle is the output from the cerebellum. That is, the final suggestions for smooth execution of the movement is passed on to the midbrain, that is the red nucleus, thalamus, and then to the cortex through the superior cerebellar peduncle. So it exits the cerebellum at the upper pons and lower midbrain and cross in the lower midbrain. Some cross fibers, as we discussed earlier, synapse with the red nucleus on the opposite side, contralateral to the cerebellar hemisphere of its origin, and others continue to the contralateral ventral lateral nucleus of the thalamus and project to the cortical motor regions from the thalamus. The middle cerebellar peduncles and superior cerebellar peduncles both cross. We have seen that the superior cerebellar peduncle crosses to the opposite side, it goes to the opposite thalamus and into the cortex. Similarly, the middle cerebellar peduncle, the information from the cortex again crosses in the pons. So each cerebellar hemisphere is connected to the contralateral cerebral cortex, and therefore the final relation, there's a double acquisition. So the final relationship between the cerebellar deficits and body is always ipsilateral. So we have seen how input reaches the cerebellum and how output goes from the cerebellum. Now, cerebellum, somebody has raised the hand. Should I like, is it for any question or?
Please continue, sir. We will take the questions at the end.
Yeah. So cerebellum is the computational center, and the importance of cerebellum as a computational center is evident from the fact that human brain contains around 85 to 100 billion neurons, and more than 50 to 60%, that is more than half of the neurons in the brain are located in the cerebellum, which occupies only 10% of the brain volume. So it is rich in neurons, rich in connections, because it does a lot of computational work. The cytoarchitecture of different cerebellar cortical regions are very similar, and they perform a similar computational process on different types of input to subserve different functions. It has got motor functions, oculomotor functions, and as we will see, cerebellum has even got cognitive and affective functions. But the information processing, there is a similar cytoarchitectural structure in different cerebellar topographical regions. So coming to the structure of the cerebellum, the inputs to the cerebellum are channeled through the mossy fibers and climbing fibers. We have seen that cerebellar input from the cortex comes through the middle cerebellar peduncle. From the rest of the body, most of it comes through the inferior cerebellar peduncle, except the ventral spinocerebellar tract, which reaches the cerebellum through the superior cerebellar peduncle. Whether it is the cortical input or proprioceptive and or vestibular input from the periphery, the input is channeled through the mossy fiber system and the climbing fiber system. Out of them, the mossy fibers can convey all corticopontocerebellar, spinocerebellar, and vestibulocerebellar inputs. While the climbing fibers, this input into the cerebellum happens through the mossy fiber and climbing fiber. All the corticopontocerebellar, spinocerebellar, and vestibulocerebellar input comes through the mossy fiber, while the climbing fiber carries the olivocerebellar inputs, which are important in motor learning. Then the cerebellar cortex is there, which is a three-layered structure, and it does most of the computational activities on the input received through the mossy fibers and climbing fibers. And output from the cortex to the deep cerebellar output from the cortex goes to the deep cerebellar nuclei. There are 4 deep cerebellar nuclei: the dentate nucleus, the globose, and the emboliform nuclei, together called interposed nucleus, or the nucleus interpositus. and the vestigial nuclei. And from these nuclei to areas outside the cerebellum, that is the cerebellar cortical output from the Purkinje cell goes to the deep nuclei, and from the deep nuclei to the outside centers, centers outside the cerebellum. There is an exception. Some of the cerebellar cortical output, particularly from the flocculonodular region, bypass the deep nuclei and directly goes to the vestibular nucleus in the brainstem. That is the only exception. All other cerebellar output is channeled through the deep cerebellar nuclei. Coming to the gross anatomy of the cerebellum. Cerebellum has three lobes: the anterior lobe, the middle lobe, which is also known as posterior lobe. Middle lobe and posterior lobe are the same, and the flocculonodular lobe. The anterior lobe is separated from the posterior lobe or the middle lobe, both are the same, by the primary fissure. This is the superior surface of the cerebellum. You can see this is the primary fissure, and this is the anterior lobe, and this is the posterior lobe. Posterior lobe forms the major part of the cerebellum. And the posterior lobe is separated from the, this is from the inferior view. The posterior lobe is separated from the flocculonodular lobe by the posterolateral fissure. And in the sagittal view, there is a midline vermis, then paravermal region that is close to the vermis, and the cerebellar hemispheres. That is functionally significant. Vermis, paravermal region, and cerebellar hemispheres, as we will see later, will perform different sort of functions. And cerebellum has got so many lobules. So this is the schematic representation of the cerebellum. If you unfold it like this, this much is the anterior lobe, this much is the middle lobe or the posterior lobe, and this is the flocculonodular lobe. You unfold it and you can see so many lobules which are named, which are numbered 1 to 10. Lobules 1 to 5 form part of the anterior lobe, 6, 7, 8, 10, 9 form part of the posterior lobe, and 10 is the flocculonodular lobe. And if you remember your first MBBS anatomy classes, you know that the anatomists called these lobules with so many fancy names, like the lingula, the Kalman lobule, the unciform lobule, paramedian lobule, biventral lobule, tonsil. So many fancy names are there. They are very important as long as you pass your first MBBS. But after that, I doubt whether they have any significance, because these lobules, they are just anatomical nomenclatures and they may not have much of a functional significance. What we need to know is the anterior lobe, posterior lobe, and flocculonodular, and these numbers. These numbers may be significant because there is a localization significance for those numbers. So cerebellum is also divided into archicerebellum, paleocerebellum, and neocerebellum, depending on its phylogenetic origin and its connections. So archicerebellum is the terminology used for mainly for the part of the cerebellum which deals with vestibular functions. This is phylogenetically the oldest part of the cerebellum. So it is basically the flocculonodular lobe and the adjacent parafloccular regions. Flocculonodular lobe and adjacent parafloccular regions, they receive connections basically from the vestibular system. Their output also mainly goes to the vestibular system, and this is called archicerebellum or vestibulocerebellum. Then paleocerebellum is the phylogenetically it evolved next, and this includes the vermis, particularly the anterior vermis, and the paravermal regions, that is areas which are close to the vermis. Vermis and paravermal regions form the paleocerebellum. It is also called spinocerebellum because its connections are mainly from the spinal cord, and output also. We found that some of the cerebellar output goes to the red nucleus, and through the rootrospinal tract, it is directly connected to the spinal cord. So that is also basically mainly from this region. So it is called spinocerebellum or paleocerebellum. And neocerebellum is the lateral lobes, mainly the lateral lobes of the posterior, the lateral hemispheres of the posterior lobe, which is predominantly connected to the cortical areas, and it has got a lot of cognitive functions also. So archicerebellum, paleocerebellum, and neocerebellum. Archicerebellum is also called vestibulocerebellum, paleocerebellum is also called spinocerebellum, and neocerebellum is also called cerebrocerebellum. So when you think of cerebellum, you have its main thing which comes to your mind is motor functions of the cerebellum and coordination. So the cerebellum has got a motor representation in the cerebellum. There is this motor representation in the cerebellar cortex, and it is not a very simple homunculus as we see in the cortex, because there are multiple representations as we can see in this picture. you can see that the anterior lobe, the vermis of the anterior lobe, that is this region, vermis of the anterior lobe is the area which is predominantly connected with axial motor functions. Your balance, your weight, all these are controlled by the vermis. While the paravermal regions and the lateral part of hemispheres of the anterior lobe, you can see that most of the anterior lobe is occupied by the limbs here. So the paravermal region and remaining part of major part of the anterior lobe controls the limb functions. Particularly the lower limb is for the lobules 3 to 4 and upper limb by lobules 4 and 5. And this area, the vermis at the junction of the anterior and middle lobes, that is concerned with eye movements. And paravermal regions of the posterior lobe also are concerned with limb functions. So paravermal regions of the posterior lobe, vermis of the anterior lobe, this is mainly concerned with axial motor functions. The lateral, and the paravermal regions and major part of the anterior lobe is concerned with limb functions. So then, and this one, the flocculonodular lobe is basically connected to the vestibular system and is associated with vestibular functions and balance. And then what about the remaining part of the hemispheres? This also has got some motor functions, particularly pertaining to the limb, but this area, that is the lateral lobes of the posterior, the lateral part of the hemispheres of the posterior lobe, they have got a lot of higher functions like cognitive functions also. So coming to the cytoarchitecture of the cerebellar cortex, cerebellum cortex has got 3 layers: the granular layer, the Purkinje cell layer, and the molecular layer. The granular layer is composed of granule cells and Golgi cells. Purkinje cell layer is composed of Purkinje cells. Molecular layer contains stellate cells and basket cells, which are interneurons. Also, it has dendritic arborizations of the Purkinje cells and parallel fibers which arise from the granule cell axons. This is the scheme. You can see the this is climbing fibers, and Mosey fiber input comes to the granule cell layer. Then you have the Purkinje cell layer here, which contains only a single sheet of Purkinje cells. And then you have the molecular layer, which is the most superficial layer, which is abundant in all these dendritic arborizations of the Purkinje cells and the parallel fibers which come from the granule cells. And these parallel fibers synapse with the dendritic arborizations of the Purkinje cells. There are also interneurons in this most superficial layer of the cortex. They are the stellate cells and basket cells. There are so many other cell types, but these are the important cell types which we should know. So granule cell layer is the deepest layer. It acts as the input layer. It contains vast number of granule cells, which is the most abundant cellular component of granule cell layer. It also contains inhibitory interneurons called Golgi cells and a few others like unipolar brush cells and Chandelier cells. The Mosey fibers, which forms the input from the cortical areas as well as the sensory, spinal sensory input to the cerebellum, terminate in granule cell layer and convey spinocerebellar, vestibulocerebellar as well as corticopontocerebellar input into the granule cell layer. So there is something called the cerebellar glomeruli. These are actually bulbous terminals of the Mosey fibers which excite the granule cells and Golgi neurons in synaptic complexes called cerebellar glomeruli. So it's a synaptic complex. There's a bulbous expansion of the Mosey fiber terminal, and it excites granule cells as well as the Golgi cells. And these Golgi cells form part of a recurrent loop and inhibit the granule cells. That is, the Mosey fiber excites the granule Golgi cell, and Golgi cell, what it does is inhibits the granule cell. Mosey fiber directly excites the granule cell also. So the Mosey fiber's effect on granule cell is excitatory, but it indirectly, through the Golgi cell, it inhibits the granule cell. So Purkinje cell layer is the middle layer, and it contains a single sheet of Purkinje cells. Purkinje cell axons conduct the entire output of the cerebellar cortex. So this is the Purkinje. This is an upside down figure. This is the granule cell layer. This is the Purkinje cell layer, and this is the molecular layer or the most superficial layer. So these Purkinje cells have got fan-like dendritic trees which extend into the molecular layer. This is the Purkinje cell layer. This is the molecular layer. The dendritic tree extends into the molecular layer, and the Purkinje cell receives input from the climbing fibers. We have seen that climbing fibers arise from the inferior olivary nucleus. So olivocerebellar fibers are the climbing fibers, and these excited Purkinje cells It also receives input from the granule cells through the parallel fiber system. That is, granule cells axons descend through the Purkinje cell layer into the molecular layer, where it forms the parallel fiber system and it excites the Purkinje cells. And then these are excitatory, the climbing fiber input as well as the Mosi fiber input, which is channeled onto the Purkinje cell through the granule cells. Both these are excitatory, while the inhibitory influence on the Purkinje cell is through the interneurons, the stellate cells and basket cells. These are excited by the parallel fibers and they inhibit the Purkinje cell. So these Purkinje cells project either to the deep nuclei, that is, majority of the Purkinje cells project to the deep nuclei and inhibit them, while a small number of Purkinje cells, particularly from the floccular nodular lobe, their axons bypass the deep nuclei and directly go into the vestibular system. So coming to the molecular layer, which is the most superficial layer, it is the outermost layer and it contains dendritic trees of Purkinje cells. You can see here that this is a Purkinje cell and this is the dendritic tree of the Purkinje cell. And cell bodies of the two types of interneurons. We have seen stellate and basket cells, and both of these inhibit the Purkinje cells. The axons of granule cells, as we discussed, they are called parallel fibers. They run, they ascend to the molecular layer, split into two, and they run parallel to the long axis of the cerebellar folia and perpendicular to the dendritic trees of the Purkinje cells. It is similar to telephone lines just passing through a tree branches. This is the Purkinje cell dendritic arterization, and these are the parallel fibers which arise from the granule cells. So these parallel fibers form synapses with a large number of Purkinje cells and excite them. So both the climbing fiber and Mosi fiber system forms excitatory synapses with neurons in the deep cerebellar nuclei as well as the cerebral cortex. Those climbing fibers and Mosi fibers, before they reach the cerebellar cortex, they send branches to the deep cerebellar nuclei and excite them. The climbing fibers, as we have seen, are olivocerebellar. They convey information to the cerebellum from both periphery as well as the cerebral cortex, because the inferior olive receives inputs from the cerebral cortex as well as from the spinal cord through the spino-olivary tracts. And each climbing fiber wraps around the proximal dendrites of the Purkinje cell like vine on a tree and results in prolonged and complex action potentials on Purkinje cells. This is thought to be important in motor learning. The Mosi fibers originate from the spinal cord and pontine and other brainstem nuclei and carry all other sort of inputs to the cerebellum, the spinocerebellar, vestibulocerebellar, as well as the corticopontocerebellar. So this is again a schematic representation. This is very important. The spinocerebellar, vestibulocerebellar, and corticopontocerebellar inputs. Corticopontocerebellar coming through the middle cerebellar peduncle. Spinocerebellar and vestibulocerebellar coming predominantly through the inferior cerebellar peduncle. They all form Mosi fibers. Mosi fibers excite the granule cells in the deepest layer of the cerebellar cortex, that is the granule cell layer. Axons go up, they split into parallel fibers. These parallel fibers are in the molecular layer, that is the most superficial layer of the cerebellar cortex, and they excite the Purkinje cells. These parallel fibers also excite the interneurons there, that is the stellate and basket cells, which inhibit the Purkinje cells. Climbing fibers are from the inferior olivary nucleus and they directly just wind on the Purkinje cell and excite the Purkinje cells. So you can see that there is a lot of recurrent circuits or recurrent inhibition in the cerebellar cortex. Excitation and inhibition converge both in the cerebellar cortex and in the deep nuclei, forming recurrent loops. And the final cerebellar output is through the deep nuclei. And there's an exception which we have discussed. Part of the output from the floccular nodular lobe goes directly into the vestibular system. And this direct excitation and indirect inhibition through the interneurons like Golgi cells, stellate cells, and basket cells. This is the integral part of, or this is the basis of the canonical sort of computation involving which is happening in the cerebellum. And this sort of computation in these loops is important for motor control as well as non-motor functions of the cerebellum. But details of how this complex interplay of circuits shapes the cerebellar output is still not known. And this is a representation of the deep cerebellar nuclei. This is the dentate nucleus. This is the globose and emboliform nuclei. And these are the fastigial nucleus. Dentate nucleus receives the input for Purkinje cell output from the most of the cerebellar hemispheres come to the dentate nucleus. the output, Purkinje cell output from the vermian and paravermal regions come to the globose and emboliform nucleus, and from the vestibule, from the flocculonodular lobe come to the vestigial nucleus. Part of the flocculonodular lobe output goes directly into the vestibular nucleus, bypassing the deep nuclei. So coming to the cerebellar motor functions and dysfunction, the major function of the cerebellum is coordination of movement. So cerebellar dysfunction, as we have seen, it does not cause weakness, but gauging and regulation of range of movements and rate and force of muscle contractions are affected, and movements lose precision and become gross, uncoordinated, clumsy, and tremulous. So there are different muscles involved in each and every movement, even in simple movements. The agonists contract to execute a movement. Meanwhile, the antagonists relax and modify the tone to facilitate the movement. And there are synergists which do not directly take part in the movement, but they reinforce the movement. And as we have seen, proximal joints need fixation, and fixating muscles prevent displacement and maintain the appropriate posture of the limb. And termination of the movement, for termination of the movement, antagonists contract and agonists relax. For example, when you want to flex the elbow, the biceps is the agonist, it contracts. And for termination, and triceps relaxes. For termination of the movement, biceps relaxes and there should be a contraction from triceps. So cerebellum is the conductor of an orchestra. It conducts the orchestra of movements carried out by different muscle groups, agonists, antagonists, synergists, fixators across different joints. So there are different joints, and for each joint there are agonists and antagonists. There will be fixators for proximal joints. So multiple joints, multiple movements. So it's even a simple movement is a big orchestra, and cerebellum is the conductor of the orchestra. And without cerebellum, the symphony of normal movements, the graceful symphony of normal movements, degenerates into a cacophony of disorganized muscle contractions. So that is what happens in ataxia. The term ataxia means lack of order. So it is derived from the Greek word which means without, and taxis, which means order. So movements all become chaotic and disorganized, and the ataxia encompasses incoordination, tremor, and impaired rapid alternating movements. It is not specific for cerebellar disease. It can also occur due to impaired proprioception. For example, there is an proprioceptive input to the cerebellum is lost, extensive, very severe degree of peripheral neuropathies which deal with which interfere with sensory input to the cerebellum. They also cause ataxia, or lesions involving cerebellar output pathways. So instead of following a direct or a straight trajectory, the trajectory becomes totally abnormal and wavy, and rapid alternating movements also become totally chaotic. And another feature of cerebellar disorders is hypotonia. It is generally seen in acute cerebellar disorders, and it may recover over some time. We know that muscle tone, it results from basically from three things. There are three mechanisms for muscle tone. One is the mechanical elastic properties of the muscle itself. Second is a background voluntary contraction, which is relieved when you totally ask the patient to relax. And then reflex contractions also play a role from the stretch reflex and other short and long latency reflexes. The reflex contractions are controlled by muscle spindles. And when the muscle spindle tone is increased, the muscle tone also increases, because the stretch reflex becomes more sensitive and reflex contractions become more active. So cerebellum has a facilitatory effect on the fusimotor tone, or the tone of muscle spindles. And loss of fusimotor tone facilitation by the cerebellum is responsible for cerebellar hypotonia. And generally, most of the conditions which cause hypotonia, whether it is an acute spinal shock of a spinal cord injury, or whether it's a peripheral nerve problem like a Guillain-Barré syndrome, whenever there is hypotonia, generally it is accompanied by absent reflexes. But this is a cerebellar disease is a condition in which hypotonia is there, but the reflexes are well preserved. So this results in the pendular nature. That is due to the lack of dampening or sprinting effect of the tone on the oscillations resulting from a normal nature. Another manifestation of cerebellar disease is dysdiadochokinesia. So abnormalities in rapid successive movements or rapid alternating movements. So the tasks which can be given to patients for this include: one is imitating screwing in a light bulb. So movements like this, or alternately slap the palm and dorsum of the hand on the thigh or on the other palm. So failure of smooth and sequential recruitment of different muscle groups happens in rapid successive movements. So these movements become erratic, or agonist switching between agonist and antagonist will not happen smoothly. That is what happens in rapid alternating movements. Dysdiadochokinesia is not confined to movements of the limbs. It can happen in speech also. And this is tested by repetition of labial, lingual, and guttural syllables. Pa is a labial syllable, ta is a lingual syllable, and ka is a guttural syllable. So when you say pa, ta, ka, sequentially very fast, this involves rapid succession of lip, tongue, and soft palate movements. And this is not possible for patients with cerebellar disease. And speech is a task which involves multiple rapid successive activity of labial, lingual, and guttural muscles. And impairment leads to scanning or staccato dysarthria in cerebellar disorders. Defects in reaching for objects is another problem in cerebellar disease. And this results from dyssynergia or decomposition of movements. The movements at various joints are not carried out smoothly, but in a series of component movements. The orchestra of movements involving different joints doesn't happen, and movements are they happen as a series of component movements. The result is that the trajectory becomes totally wavy and erratic. In dysmetria, there is an incorrect gauging of the range of movement and force to be generated to reach the target. The result is that the limb will either overshoot, that is hypermetria, or undershoot, that is hypometria. And this also leads to increased path curvatures, corrective movements, and slowed and highly variable velocity profiles. And one peculiarity is that this dyssynergia and dysmetria is speed and inertia sensitive. That means when you try to do it fast, dyssynergia and dysmetria become much more prominent. And in an attempt to reduce dysmetria and dyssynergia, the patient may make all these movements extremely slow. So dysmetria and dyssynergia are tested by finger to nose test and heel to knee to shin test. We will see videos later towards the end of the talk. Rebound phenomenon is tested by the Stewart-Holmes maneuver. The patient attempts to move the limb against resistance given by the examiner, and the resistance is suddenly removed. The normal response is that the limb will usually move to a short distance in the original direction, and then the antagonist muscle will contract, arresting the movement and bringing the limb back into the opposite direction. A complete absence of the phenomenon or failure of the antagonist muscles to contract is seen in cerebellar disorders. Localization of dysmetria and dysdiadochokinesia. It is typically seen in lesions of the anterior lobe and the cerebellar nuclei, particularly the globus and embolium, that is the interposed nuclei and the dentate nuclei. And upper limb dysmetria, as you can see in this picture, results from lobules 4. Upper limb dysmetria results from lesions of lobule 4 to 6, and lower limb dysmetria lesions of lobules 3 to 4 of the anterior lobe. Tremor is another feature of cerebellar disorders. The most important mechanism for tremor is an attempted correction of deviation from the trajectory or the target. And this leads to overcorrection. And again, a correction is attempted. And this cycle continues as a vicious circle. That is the mechanism of cerebellar tremor. And there is also a central oscillator, that is a disordered cerebello-rubro-thalamo-cortical loop, which is also hypothesized as a mechanism for cerebellar tremor. Intention tremors are the most considered to be the classical type of tremor in cerebellar disease, and they occur with goal-directed movement when the patient is achieving towards moving towards a target. And these are worse while the patient approaches the target. While other types of tremors also can occur in cerebellar disorders, postural tremors as well as kinetic tremors. Postural tremors occur in an outstretched hand in the line of gravity. Hand is outstretched against gravity, and you get tremors in the line of gravity. While in kinetic tremors, the tremors occur throughout the goal-directed movement, unlike intention tremor, where there is a worsening when the patient is reaching the target. These also occur in cerebellar disease, even though intention tremor is considered to be the classical type of tremor in cerebellar disease. And all areas of the cerebellum are directly or indirectly involved in gait control mechanisms. So gait ataxia and truncal ataxia are cardinal manifestations of cerebellar disease. But when gait ataxia occurs as an isolated phenomenon, that is, only gait ataxia is there without much of limb involvement, and the presence of titubation is also there, it generally indicates a lesion in the midline or vermial region, particularly the anterior vermis of the cerebellum. And this is typically seen in those with alcoholic cerebellar degeneration, where the anterior vermis is classically affected. The gait becomes clumsy, staggering, and wide-paced. There is an increased step width, decreased step length, low gait speed, reduced cadence, and increased duration in stance and double support phase of walking. And on standing still, the body may sway back and forth and from side to side. This is called titubation. And patients are not able to walk from heel to toe or walk in tandem. And the locomotor abnormalities reflect poor limb coordination and impaired balance. This greatly restricts patients in their activities of daily living and predisposed to falls. And coming to oculomotor disorders, oculomotor dysfunction cerebellar disorders, the purpose of normal eye movements, one is to optimize vision by accurately bringing the images to the fovea where visual activity is best. This is achieved by the saccadic system and the vergence movements. The purpose of saccades and vergence movements, these are fast movements. These are to bring the object of interest, the image of the object of interest to the fovea. Once it is brought to the fovea, this needs to be stabilized even when the head or the object at which we are looking at is moving. So the stabilization is done by the fixation, smooth pursuit, and vestibulo-ocular reflex mechanisms in the brain. So precision and coordination of eye movements, all sorts of eye movements is very important for a proper binocular vision. And cerebellum plays a very important role in all eye movements by providing calibration, just as it provides calibration to other movements of the limbs. So cerebellar disorders lead to a variety of oculomotor abnormalities. It can manifest as ocular instability in the form of nystagmus and saccadic intrusions, disturbances of voluntary eye movements, or even ocular misalignment, that is Q deviation or esotropia. So cerebellar structures important in oculomotor control include the flocculus and paraflocculus regions, that is the vestibulocerebellum, nodulus, that is the flocculonodular lobes, the midline part of the flocculonodular lobe, the uvula and the vestigial nucleus, and also the oculomotor vermis. The oculomotor vermis comes in this region, that is the junction of the anterior and middle lobes of the cerebellum. The vermis in that area represents the oculomotor vermis. So oculomotor vermis and flocculonodular region, these are the areas which are important in eye movements. And there are, due to ocular instability, different types of nystagmus occur in cerebellar disease. Downbeat nystagmus is the most common one, where the fast component is towards downside. And this is elicited by asking the patient subject to look to the side and down. And then gaze-evoked nystagmus and rebound nystagmus are other types of nystagmus. These are one of the most common forms of central nystagmus, but these are not very cerebellar specific. Even in brainstem lesions, you can get gaze-evoked nystagmus. In gaze-evoked nystagmus, the direction of the nystagmus is towards the gaze. If you look to the left side, the fast component will be towards the left side. If you look to the right side, fast component will be towards the right side. Others include periodic alternating nystagmus and central positional nystagmus. I'm not going into the details for shortage of time. Other oculomotor abnormalities which are common in cerebellar disorders include saccadic intrusions. That means saccades come involuntarily without the patient's willful attention. The most common saccadic intrusion is square wave jerks. These are small horizontal saccades of around 0.5 degrees. As saccades are rotational movements, so the amplitude of saccade is expressed in degrees. So square wave jerks are very small saccades, spontaneous saccades around 0.5 degrees, which take the eye away from the fixation point, and immediately eye returns to the fixation point. So it is elicited by asking the patient to look at a finger, and you can see these jerks happening in between. And macro square wave jerks are larger, much more evident. They are generally larger than 5 degrees. And these are also not very specific to cerebellar disorders. And then there is ocular flutter and oxycrones. These are also saccadic oscillations, but the difference is that there is no intersaccadic interval. For square wave jerks, when saccade occurs, there will be an interval after that. While in ocular flutter and oxycrones, these are saccades which occur continuously without an intersaccadic interval. And difference between flutter and oxycrones is that flutter occurs in the horizontal direction only, while oxycrones occurs in multiple directions. And they often appear as bursts of saccades with a frequency of 10 to 25 cycles per second without an intersaccadic interval. These may be intermittent, and these are sometimes triggered by normal saccades. You ask the patient to look to the side, and patient develops a flurry of ocular flutter or oxycrones. In addition to these saccadic intrusions, patients also will have deficits of slow eye movements. One is the impaired smooth pursuit movement. The tracking of an object is achieved only with catch-up saccades. When you are following a moving object, generally your eye moves very smoothly. But in cerebellar disorders, you find that there is a lag, and this is compensated by a catch-up saccade. This is called saccadic pursuit. And vestibulo-ocular reflex also is generally impaired in patients with cerebellar disorders. We will see in the video how it is elicited. And voluntary saccades also are abnormal in cerebellar disorders. How you examine for voluntary saccades is you ask the patient to fixate on a central tablet. That is, you ask the patient to look at the examiner's nose and you keep a finger or a pen in the periphery and then ask the patient to suddenly shift the gaze to the peripheral tablet. That is from the examiner's nose to the pen or the tip of the finger. And you can see that in cerebellar disorders, there is saccadic dysmetria. That is, saccades become either hypometric. They undershoot, they do not reach the target, they stop, and again with another catch-up saccade, it reaches the target. Sometimes there is saccadic hypermetria, that is, it goes beyond the target and then with another saccade in the opposite direction, it comes back to the target. Saccadic is lateral pulsation is a situation in which towards to one side, patient has got a saccadic hypermetria. When you look to the other side, you see that patient has got a saccadic hypometria. And generally the lesion is on the side of the hypermetric saccadic hypermetria. And skew deviation is a non-paralytic vertical ocular misalignment that is observed in all gaze directions. It more frequently manifests as alternating skew deviation in cerebellar disorders. That is, changing direction with change in the horizontal eye position, abducting eye being higher. So abducting eye will be higher, adducting eye will be lower. So there is an ocular misalignment in the vertical direction. And esotropia means there is an inward movement, which is non-paralytic. So this is the localization for oculomotor abnormalities. Flocculus and paraflocculus is the common area, is an area where oculomotor abnormalities are very common. You get downbeat nystagmus, gaze-evolved nystagmus and rebound nystagmus, impaired smooth pursuit and impaired vestibulo-ocular reflex when flocculus or paraflocculus region is affected. For nodulus and uvula also, you get a periodic alternating nystagmus, central postural nystagmus, head shaking nystagmus. When there is a vigorous head movement, nystagmus is precipitated, and skew deviation. When the oculomotor vermis is affected, you get saccadic hypometria, impaired smooth pursuit, and esotropia. And fastigial nucleus, again, saccadic hypermetria, impaired smooth pursuit, and square wave jerks. Vertigo and dizziness also occur in lesions of the vestibulocerebellar and vestibulospinal or cerebellar oculomotor systems. Acute onset symptoms lasting days to weeks typically is seen in cerebellar stroke, hemorrhage, and encephalitis, while chronic progressive conditions like hereditary ataxias, cerebellar tumors, inherited metabolic disorders, etc., generally do not cause vertigo and dizziness because the system gets familiarized and then that it tends to fatigue, and patient generally doesn't report vertigo or dizziness. Finally, coming to the cognitive and affective functions of the cerebellum. So we have found that even though clinical manifestations of cerebellum are predominantly motor, cerebellum has got areas which are actively involved in cognitive and affective functions. And this graph shows the distribution. There is no absolute compartmentalization. There is a lot of overlap, but mainly the lateral part of the hemispheres of the posterior lobe, they are mainly involved with cognitive functions. And the vermis, you know that the anterior vermis, the vermis of the anterior lobe is concerned with axial motor functions, while the vermis of the posterior lobe has got affective, that is emotional functions. So, this is not like the posterior vermis is concerned with the affect and behavior. That is the limbic cerebellum. It has got connections with the limbic areas of the brain, which are concerned with emotion. While the left side or the lateral lobe of the left side of the posterior lobe, that is concerned with visuospatial function and executive functions, while right side is concerned with language function and executive function. You know that language is a left hemispheric function for the cerebrum, but the left side of the brain is connected to the left side of the cerebrum is connected to the right side of the cerebellum. So accordingly, the right side of the right hemisphere is concerned with the language functions. So but it is more of theoretically. Very rarely only you will see patients with cerebellar disorders complaining of cognitive symptoms. That is because cognitive deficits arising from cerebellar damage can be difficult to characterize. The cognitive test results may be very variable, and patients perform sometimes normally in one test, but may not perform normally in another test. And these deficits are most pronounced when patients are tested shortly after that damage. But When in the acute phase of cerebellar disease, patients will be severely disabled by their motor symptoms, so cognitive testing is often not possible. And compensations at level of cerebral cortex might gradually make up for the cerebellar loss of cognitive functions. So by the time the motor functions improve to some degree, cognitive functions almost fully recover because the cerebrum takes over the cognitive deficits, say takes over and compensates for the cognitive deficits resulting from cerebellar dysfunction. The cognitive deficits are more robust and long-lasting when cerebellar damage is acquired in childhood. And motor dysfunction after cerebellar damage is more obvious than cognitive dysfunction. The cortical regions of motor control are less able to compensate for loss of cerebellar motor control compared to cortical compensation for impairment of cerebellar computations involving cognitive process. So cerebellum must play a cognitive role. And on testing patients, you will find abnormalities in cognition, but it is often not clinically evident, or it doesn't come as a symptom, because in the acute phase, very often patients are disabled by their motor deficits, and you will not be able to test. And the cerebral cortex is able to take over the cognitive functions very fast, so that in the subacute phase or chronic phase, it may not be manifest as a symptom. That is the reason why, even though the cerebellum has good cognitive functions, it is not often very evident in routine clinical practice. So there is something called Schmann's syndrome, or the cerebellar cognitive affective syndrome, which has got components including executive dysfunction, linguistic abnormalities, abnormalities of spatial cognition, and personality changes. This may not come forth, as we discussed, this may not come forth as a symptom from the patient. You may, if you go into cognitive examination, you may find these abnormalities. We can quickly see some of the videos, some typical videos in patients with cerebellar disorders. This video shows, these are only basic clinical examination abnormalities. You can see significant degree of gait ataxia in this patient. This is a patient with an autosomal recessive ataxia syndrome. She is unable to walk tandem, and there is tendency to sway. So on doing the finger nose, you can see the overshooting hypermetria very clearly, because the finger is overshooting the target and then it is coming back. And the trajectory is also wavy. It is not a straight trajectory, it is wavy, and the intention tremor component is also evident. This is a video to demonstrate dysmetry and dysdiadochokinesia. You can see the overshooting and or undershooting, and then attempted corrections for that. And intention tremor is also evident. Towards the target, the patient's hands become tremulous. And in the trajectory, it is not very wavy, but once it reaches the target, you can see that the tremor is worsening. And for testing the intention, intention tremor, all the joints should be in action. So the the shoulder also should be held in abducted position, and there should be full range of movement in the elbow. Then only the intention tremor component will be evident, as it is shown in this particular video. And this demonstrates dysdiadochokinesia. The rapid alternating movements are totally erratic. You can see the variations in amplitude and variations in the rhythm which is happening. So it is totally erratic. The speed is reduced, and the movements are happening without a proper coordination. The switching between agonist and agonist is not happening. This is how we do the heel shin knee test. You can see the same pattern of intention tremor and incoordination with the volume. So this This demonstrates the typical gaze-evoked nystagmus. You can see that on looking to the left side, it is beating towards the left side, and looking to the right side, it is beating towards the right side. Nystagmus has got a fast component as well as a slow component. When she is looking to the right side, the fast component is towards the right side. When it is looking towards the left side, it is the fast is towards the left. There's a fast component which is towards the direction of gaze, and there's a centripetal slow component. When the eyes are kept eccentrically, it gradually drifts to the neutral position, and a saccadic correction takes it to the eccentric position again. Again, it drifts back. That is a mechanism of gaze-evoked nystagmus. So obviously, it would be towards the direction of gaze. Same patient, you can see that the gait is ataxic, wide-based, and she is also unable to walk tandem. So this is a child with, you can see that it is not only ataxia, there is something else also which is present in this child. It's a little old video. This child has a typical chorea. So this child has coriform movements, and he is also ataxic. You can see that he is standing with a wide base. He's having a highly ataxic gait. And you can see that there is an oculomotor apraxia also. Whenever the child is asked to look to the side, when saccadic movements are tested, you can see that child is doing a head jerk. There's a jerking of the head and it is moving, and you can see telangiectasia in the conjunctiva. It's a child with ataxia telangiectasia with oculomotor apraxia, ataxia, and chorea also. Chorea can happen in patients with ataxia telangiectasia. And this video, this is a patient which we published recently. Quite recently, it came in movement disorders clinical practice. It's a patient with anti-SIG4 antibody-related paraneoplastic neurological syndrome. She presented with ataxia, and on evaluation, she was found to have a lung cancer, and anti-SIG4 antibody was positive in her. So she has many of the manifestations of cerebellar disease. So you can see saccades with normal velocity and gaze-evoked nystagmus. Saccades are normal, but you can clearly see the gaze-evoked nystagmus in her. So looking towards the left side, it is beating to the left. Looking towards the right side, it is beating towards the right. And she also has downbeat nystagmus and gaze-evoked nystagmus in the vertical direction. So this is the saccadic pursuit which we discussed. You can see that when she is following an object, it is not a smooth movement. Instead, if you watch very carefully, you can see that it is by multiple saccades. It is not a smooth pursuit movement, but instead multiple saccades are happening because pursuits are slow and there's a compensatory. So this is how you look for head thrust. You can make a passive movement. See, once again, head thrust is normal. How you do head thrust is you ask the patient to look at fix the gaze on an object, gaze on your finger. You show the finger, ask the patient to fix the gaze on the finger, and then suddenly make a passive jerky movement of the head. Normally what happens is that the gaze should remain fixed on the finger itself because the vestibulo-ocular reflex is normal. So in those with normal vestibulo-ocular reflex, the gaze will remain in spite of the head being moved to one side or the other. The gaze will remain fixed to the finger to the target. But in those with impaired vestibulo-ocular reflex, what happens is that gaze drifts away, and with the catch-up saccade, it again comes back to the normalcy. This is normal response. But this patient had impaired with POR suppression with fixation. how it is done is normally when you turn your head, the vestibular ocular reflex becomes active. But when you ask the patient to fix and then you rotate the head or rotate the whole body, what happens is that the vestibular ocular reflex is suppressed. So you make the patient, it's a very artificial situation. You make the patient sit on a rotating chair and keep your finger in front of the patient. You rotate the chair and you rotate the finger also around the patient and ask the patient to keep the gaze fixed. That is, chair is rotating, your finger is also moving around that at the same rate, and then there should not be any saccadic intrusion. That is, patient should be able to fix it. That is because that normal vestibulo-ocular reflex, which should become active when the chair or the head is rotating, is suppressed normally by the fixation. But in this patient, the vestibulo-ocular reflex is not suppressed by fixation. That is, when the head is rotating and the finger is moving along with that, you can see that there are catch-up saccades which are happening. It is clearly evident. Look at her eyes. You can see that when the head is rotating, eyes are drifting away, and with catch-up saccades, they are coming back to the fixation target. So this is what is called impaired BOR suppression by fixation that is seen in cerebellar disease. This patient has got upper limb dysmetria. Left side, there is a clear-cut dysmetria. Right side, it is not. And she has a significant degree of ataxia. And her gait is wide-based and unsteady with eyes open. And surprisingly, you can see that her gait is wide-based and unsteady. Gait improves when eyes are closed. This is a phenomenon which you get in oscillopsia. When there is a significant degree of oscillopsia, which is seen in patients with impaired vestibulo-ocular responses, when you walk, when there are head movements, the fixation will not be correct. Eyes will be continuously moving. Patient will not be able to fix. And because of that, there will be oscillopsia. The environment will be dancing. Patient will have a feeling that the whole environment is moving because of the defective vestibulo-ocular responses. So such patients, when they try to walk with eyes open, the oscillopsia will significantly interfere with gait and they may feel highly ataxic or imbalance will be there. But these patients will be able to walk better with eyes closed. So finally, the take-home points. So basal ganglia circuits select and initiate the movement patterns most appropriate for the situation, and the cerebellum gauges the kinematic characteristics, that is the range of movement, force of muscle contractions needed, etc. Fine-tunes and coordinates various movement components for smooth execution. The corticospinal system, that is a UMN system, and the motor unit, the anterior horn cell, peripheral nerve, neural muscle junction muscle, that is LMN, forms the final common pathway of motor commands to the muscle. For fine-tuning and coordination and ensuring precision of body movement, cerebellum needs information on what the brain wants the body to do, which reaches the cerebellum through the cortico-pontocerebellar fibers. And what is the precise position of each body part in the space, which reaches cerebellum through the spinocerebellar, trigeminocerebellar, and vestibulocerebellar pathways. There is a complex computational system in the cerebellum involving the cerebellar cortex and deep nuclei, which integrates the internal schema of position of the body part in space derived from sensory and vestibular inputs, and a copy of motor commands from cerebral cortex for fine-tuning of movements. The final output is delivered by the deep cerebellar nuclei. Cerebellum is involved in all types of voluntary movement, including eye movements, gait and postural mechanisms, and fine limb movements. So deficits of cerebellar function manifest as ataxia. The anterior vermis is involved in axial motor functions, that is gait, balance, and truncal movements, while the rest of the anterior lobe and paravermal regions of the posterior lobe are involved in limb movements. The flocculonodal lobe is primarily connected to the vestibular system and is involved in balance mechanisms. The flocculonodal lobe, parafloccular regions, part of the vermis, and the vestigial nucleus are involved in eye movements. Cerebellum, particularly the lateral parts of posterior lobe and the posterior vermis, have cognitive and affective functions. The deficits in these domains are less noticeable compared to motor, as the cortical regions are quickly able to compensate to a major degree for the cerebellar dysfunction. Thank you. Can I stop screen sharing?
Yes, sir.
Thank you, sir. Thank you for the excellent exposition of the topic. And it was a really nice to hear from you about an elaborate and excellent discussion of the topic. And to summarize, sir has begun with the anatomical divisions of the cerebellum, the anterior lobe, the posterior lobe, the flocculonodular lobe, and the various lobules or the lobules coming under these each lobe. And then he went on to explain about the phylogenetic classification of archicerebellum, paleocerebellum, and the neocerebellum, and the anatomical lobes which correspond to these divisions. And then he went on to discuss about the peduncles, the inferior cerebellar peduncle, which is the main input to the cerebellum, and the superior cerebellar peduncle, the main efferent or main output from the cerebellum, and the exceptions to this tracts which go through these peduncles, namely the ventral spinocerebellar tract, which is not going through the ICP. Instead, it goes through the superior cerebellar peduncle. And then he went on to describe about the topographic representation of the body over the cerebellum, and then cellular architecture, the 3 layers, and how these massy fibers and the chyming fibers, all these fibers, they interact, and excitation inputs, as well as the inhibitory circuits, and about the clinical features. What are the clinical symptoms and signs we come across whenever we come across a child with a person with a cerebellar lesion, and the reason for each clinical symptomatology, and how to localize about this hypotonia, dysadiadokinesia, dyssynergia, dysmetria, and this tremor, and oculomotor manifestations, various types of nystagmus, which type of nystagmus is specific and classical to cerebellar lesion, and what are the other types of nystagmus which can occur with the cerebellar lesion, and about the other oculomotor manifestations, namely square wave jerks, then your ocular flutter, opsoclonus, and how to look for all these things he demonstrated. And we really appreciate you, sir, and we really had a very nice time in seeing all these things and hearing from you. And finally, he dealt upon the cognitive non-motor functions of the cerebellum, also about the cognitive functions, about the language function, about the affective functions also. And it was very nice, and we are very glad to hear from you, sir, about this topic. Thank you very much for the nice exposition of the topic and detailed demonstration and elaborative talk on this topic, sir. Thank you very much.
Thank you, madam. I think there are a few queries in the comment box.
Yeah. Thank you, sir.
Yeah, over to
lecture.
Rachna.
I think Dr. Rakshana has now joined today. Thank you so
I
much,
see.
sir, for the excellent lecture and also for simplifying this complex topic. It was a very great learning experience for all of us. So there are a few questions from the audience. What is the clinical localization in children with opsoclonus in cerebellar disorders?
Opsoclonus, generally opsoclonus is seen in diffuse cerebellar involvement conditions, inflammatory conditions which cause diffuse cerebellar involvement, but it is mainly the oculomotor dermis, the vestibulocerebellum, that is the flocculonodular lobe and the fastigial nucleus, which are the localizations mentioned in literature for opsoclonus.
Thank you, sir. If chronic pathology causes compensation of cognitive cerebellar deficits, why cognitive deficits are more robust when acquired in childhood? Will they not get compensated by cerebrum?
I am not sure regarding the answer. I can what I can think of is that as it is a chronic disorder which has developed during the developing phase, you know that when the cognitive capabilities, like there is a lot of pruning happening in the in the neural circuits. A lot of synaptic connections are initially formed and then they're pruned during the development of the cognitive process. So if the cerebellar function is impaired during this crucial stage in which the neuronal connections and pruning is happening, probably it has got a negative effect. It has got a long-standing effect and clinically overt effect. That is what I can propose, but I have not read anything in literature, or I do not have an answer which is supported by studies. Childhood is a period during which all this evolution and all the synaptic plasticity and connectivity is happening and all the synaptic pruning is happening. And during that phase, if the cerebellar support is not there, probably it may become more evident. That is an explanation which I can propose.
Okay, sir. Is motor control of cerebellum truly unilateral? Or is it contralateral, or is it a mixture?
Cerebellar hemispheres are connected to the contralateral cortex and contralateral inferior olivary nucleus. Inferior olivary nucleus again receives cortical and spinal input from the same side. So it is largely contralateral, but certain things like gait, even in unilateral cerebellar disorders, even though gait is predominantly a midline cerebellar function, cerebellar hemispheric lesions also can impair gait, because gait is something which has a very complex integrative, in which a complex integrative mechanism of multiple faculties is needed. So, so purely unilateral lesions also may result in bilateral dysfunction, particularly pertaining to gait and balance, but otherwise largely it is ipsilateral.
Okay. So you said that cognitive tests may be variable in patients with acute cerebellar pathology. So what would be the correct way of assessing the cognitive deficits in these patients?
You can, it may not be clinically for the patient. Functionally significant cognitive deficits are, I don't know, because I have very little experience with acute cerebellar disorders in children, because I am basically an adult neurologist. In adult neurology, functionally significant cognitive deficits with cerebellar dysfunction is extremely uncommon. But on testing, for example, there may not be any evidence for a frontal executive dysfunction, but if you test, like if you apply a Stroop test or a frontal assessment battery, you may find abnormalities. How to demonstrate, because some of the tests may be normal. Say there are the numerous tests for frontal dysfunction. You can do a Wisconsin card sorting test, you can do a trail making test, FAB can be used. You can use multiple so that some of them will pick up abnormalities. That is the only option, because in some tests patient may perform normally and some he may perform abnormally. So that is a problem with the cognitive dysfunction cerebellar disorders. Practically, it is never. It almost never comes to a practically relevant level. So it is more of a theoretical interest. You may do multiple tests to see whether any of them are abnormal.
Any role for DTI studies in cerebellum pathology and localization of function in cerebellum in human? Comments, please.
I didn't get the question. Any role for?
Any role for DTI studies in cerebellar disorders?
Detailed study.
DTI, diffusion
tensor imaging. Maybe because all these cognitive deficits occur because there is a connectivity issue with the cerebral brain. So diffusion tensor imaging and tractography would be of help, but I am not aware of any studies.
Sure, sir. Cerebellum and cognition you have discussed already in detail. One of the attendees has asked, is there any evidence and how do we assess in clinical practice? I think you have already answered in your
Yeah, it's already answered.
Yeah, I think there are no more questions. So I sincerely thank our speaker, Shyam Krishnan Nair sir, for the excellent lecture, and our moderator, Professor Lima Paulin ma'am, for moderating the sessions today. Thank you, sir and ma'am. Sneha, can you please share the calendar for November month?
Yes, ma'am.
Good evening, all. Thank you, Dr. Sangeeta, Dr. Shyam Nair, and Dr. Lima Pauline, ma'am, for this wonderful session. The next month is Epilepsy Month, and we have AOC and Back to School Days, which are primarily targeted at epilepsy. There is the first session is basically on the Journal Club, which is going to discuss about the febrile seizures. The second fundamental lecture series is on the stepwise basic approach to seizure and epilepsy. And advanced pediatric neurology lecture for pediatric neurologists is targeted, and we have a very interesting speaker, Dr. Robert Fisher, for neuromodulation for epilepsy. And the allied specialty talk is also a very interesting talk on neuroimaging and epilepsy. So hope to see all of you the entire next month celebrating the epilepsy month next month. So this is themed purple for this reason. Dr. Sangeeta?
Upcoming week, we have the Journal Club presentation. We'll be having two topics, a Cochrane review discussion on prophylactic drug management for febrile seizures in children. Another on a journal review, febrile seizures and epilepsy, controversies and consensus. The presenters will be Dr. Gaurav Gautam from AIMS Jodhpur and Dr. Tanya from PGIMS Rohtak. The moderators for this session would be Dr. Lokesh Saini from AIMS Jodhpur and Dr. Kaushik from PGIMS Rohtak. And Dr. Bishwara will coordinate this session. Dr. Kavita, do you want to add anything?
No, I think we can wind up. It was an
Thank
excellent
you.
session. Yeah.
Thank you.
Thank you so
everyone.
much,
Thank
everyone.
you,
Thank you.
Shyam
Thank
sir.
you.
Thank you, Dr.
Thank you.
Leena.
Thank you, madam.
all the
Thank you, sir.
coordinators.
Thank you.
Thank you,
Thank you
Kavita,
very
ma'am.
much.
Good night, everyone.
Good night.
Right.